I have been provided with two images of barium swallow study of 70-year-old female patient, frontal and lateral projection, in which I can see that the contrast is seen specifying esophagus with evidence of multiple areas of structural narrowing and with evidence of dilatation and patchy area of mucosal irregularity. However, contrast is seems to be passing beyond these area of narrowing distally into the esophagus. Keeping in view the age of the patient and the presenting complaint of dysphagia, and on the basis of the findings of structural narrowing with mucosal irregularity, I will consider any mucosal growth in the proximal esophagus and in the region of hypopharynx. And I would like to proceed the case by looking at the other images of this study, and further would advise CT scan examination of the patient in order to delineate the extent of the disease process. However, on the basis of these imaging, I can appreciate, I can conclude that this is any growth within the hypopharynx or the proximal esophagus, which is causing the mucosal irregularity, shouldering, and narrowing.
Very good. It's good enough description, good enough conclusion. Okay, you must speak about this shouldering, this abrupt narrowing, and this complete mucosal disruption. These are the
Right,
words
sir.
they will support your diagnosis. Even before that, you speak out the diagnosis. And then the other films to get the full length of the esophagus, the full segment of the esophagus which is involved. And with
Right,
all
sir.
these, you are to confirm with OGD biopsy. And in your
Right.
description, you must try to explain, you must try to differentiate. First, the structure, it is uh, correlating with the lateral view or oblique view, it is circumferential. There is shouldering, there is
Right, sir.
complete mucosal disruption. You are to, with all these sportive words, you are to differentiate it from the benign structure, to confirm it, to
Right.
just speak out as it is a malignant structure. Then for confirmation of malignancy, OGD and biopsy. And when confirmed
Right, sir.
carcinoma esophagus, you have to then go for, they say, staging CT. Okay?
Sir, I am presented with the plain X-ray chest and upper abdomen of the skeletal immature patient of a pediatric age, and two films of the barium swallow. Uh, on the plain X-ray, I can see the complete opacification of the right lung field. Left lungs appear unremarkable. Uh, and also I can appreciate paucity of gases in the right side of the abdomen under the diaphragm. And in the contrast study, the contrast is seen opacifying the upper part of esophagus. No contrast is seen beyond that. So likely this is the festal, atresia.
Yeah, it is just a spa diagnostic film.
Right,
Okay?
sir. Okay, sir.
Okay, when you see right thorax is opaque, the next you have to speak about the mediastinum to differentiate between whether it is consolidation or collapse consolidation. You see the heart is just sunken into that opacity of the right hemithorax. It is marked ipsilateral mediastinal shift. You must speak out. There is the over-pneumatization of left lung, compensatory to the right, okay? There is collapse consolidation of the right lung and why that is there. And there is air in the visible stomach and the gut loops. This all is liver.
Right, sir.
Okay,
Okay, sir.
then there
Okay,
is
sir.
abrupt cut-off effect. There is abrupt blockage to the contrast just above the level of carina.
Right, sir.
Okay,
Right.
and this is at this age when there is difficulty of feeding, and at this age it is typical of esophageal atresia. What is the type
Sir,
of it?
um, sir, is complete. Sir, this type what you were asking about the type, sir.
Type of this in this case, what is the type of test atresia?
Sir, actually, I can't remember. Sir,
If you can't remember
sir,
this, you must go and remember forever. This is the
sir,
next
I.
question.
Okay, sir.
Frankly, the surgeon will
Right.
straightway ask it. What is the type of this?
Sir, type
And
E, sir, isolated. It is just type A. It is just.
Nana,
I.
speak on this patient straightway.
Sir, complete. Sir, type A. It is just, sir.
Type A atresia. Can't you see the air in the stomach? You have to go
Oh.
accordingly.
Yes, sir. I can see, sir. So,
But
sir,
the
it is a
contrast
top.
in this case, at this age, with this clinical scenario, what the contrast you will prefer to use in this case? Oral contrast.
Sir, barium, sir.
Okay. Barium. Why not gastrography? Why not
Because
non-manual?
it can cause irritation to the lungs, and it's not used in the pediatric population
Very good.
suspected for this disease, sir.
Gastrographin is never to be used because it is highly hypertonic and cause lot of pulmonary irritation, pulmonary edema, and patient can choke and die. Never
So
ever
sorry to. Yes.
gastrographin. Never ever gastrographin. Always in such a delicate patient, even more preferable than barium is non-ionic.
Right,
Okay.
sir.
These are the three barium swallow images, often mature skeleton. There is contrast is noted specifying the upper part of the esophagus. There is opacification of tracheobronchial tree on the right side in the second image, and on the third image there is bilateral opacification of the tracheobronchial tree. So this is representing tracheoesophageal fistula.
Okay. Looking at this, what would you like to do next? What will your action?
I
That
will
you
stop the
proceed?
examination uh, at that time,
You will
and
what?
I will, if I will present there, I will stop the examination as the patient has swallowed the aspirate the barium, and then I will go for the investigation to what's the causes of this fistula.
Okay. Very good. You stop the procedure. You have to help out the patient with the head down to cough out
Yes,
all the
to cough
contrast
out the
immediately.
contrast.
You will have to see the oxygen availability, and then help out the patient from this choking emergency. Okay.
Yes.
Then next is what to do. You have confirmed the aspiration, you have confirmed the fistula, and you have confirmed this
There is a filling
esophageal
defect in
complete
upper esophagus,
blockade.
and
Okay. Then one can go for OGD, one can go for CECT, chest, abdomen, even neck, and we can go out. Basic in this is the response of the candidate to the patient when he is going to be choked, when he is aspirated a lot of contrast, he is coughing, and he
please
is
focus.
uh,
So, sir, I'm provided with two spot images from barium swallow examination of a 38 years old male patient, focusing the distal part of the esophagus, in which I could see the AP and oblique views, in which I see that the contrast is seen trickling from a narrowed part of esophagus at the gastroesophageal junction. There is an area of luminal irregularity and luminal narrowing and mucosal irregularity, which is appearing as shouldering on oblique views, suggestive of a circumferential abnormality. This is resulting in abrupt change in caliber of the esophagus, and this is a relative long zone of structure narrowing, which is also resulting in disruption of the normal Thornwald appearance of the gastroesophageal junction. However, I could see that contrast is seen trickling distally beyond it. The proximal visualized part of the esophagus is showing normal mucosal outline, and there is no significant holdup of contrast noted. So here I would
Okay.
like to give
So,
differentials.
so far, very good. So, what is this?
So sir, this appears to be an extrinsic compression over the esophageal lumen
All
on
this
this.
extrusion.
Sorry,
What
sir.
is this? Any idea? It is ulceration and the process inside the mass. And the
Right, sir.
contrast is folding. Okay, the contrast. And there is a whole bulk of the lesion over here.
Right,
Over
sir.
here, there is no opacity. The lesion is limited. Okay.
Yes, sir.
What is the possibility?
Sir, considering the appearances, I would raise possibility of a neoplastic lesion since I see that there is involvement of the gastroesophageal junction. This is more likely to be a adenosphere rather than a squamous cell carcinoma.
Okay. Any other possibility?
Another possibility could be an
Do
extrinsic
you remember
mass
the
lesion.
age of the patient?
Yes, sir, 38 years old. Another possibility could be of chronic reflux disease resulting in erosive ulceration and
Okay, that will not give you such a shouldering,
yes, sir, exactly.
not such big ulceration. That is a different appearance, different outlook. This is a large bulk of the mass over here. Okay, and there is passage of contrast on the side in AP view.
So,
And when describing such studies, you have to describe in a lump sum concept. If you describe the films individually or later view, I see this, on AP view, I see this, that is wastage of time. And your description should be lump sum, a conceptual one. Okay. Then what are the possibilities at this age?
sir, this could be a
Okay.
uh,
Cerebral and adjacent gastric lymphoma confirmed on OGD biopsy.
So I am provided with three spot images of barium study, upper GIT study, double contrast barium meal studies, and here I can appreciate that opacification of the contrast within the stomach, and it is also outlining the duodenum. Mm, Here I can appreciate the thickened mucosal folds. They are appreciated within the fundus and body of the stomach. And however, no contrast exacerbation is noted, and I can see that mild narrowing is noted at the region of pyloric antrum and proximal part of the duodenum.
Okay. Sum up. What are the possibilities? Your description adequate.
Yes, sir.
You,
So based
you
on
have
these findings,
reached to the lesion. Now you have to uh, come with the possible diagnosis, provisional diagnosis, and then the possible differentials. It is
yes,
a
sir.
large, lobulated, persistent filling defect in DJ, duodenal
Yes, sir.
division. Okay, and there is a lot
Yes.
of dilatation of duodenum, stomach is
Yes,
quite
sir.
good, normal, guarded by pylorus. Okay,
Yes, sir.
mucosal fold
Yes, sir.
little prominent, little but within the normal range. Okay, what is this?
Yes, sir.
This all
Yes, sir.
is
Sir, based on these
causing
sir,
great
based on
problem.
these findings, sir, it is likely. Yes,
It
sir.
is what?
Sir, these are sir likely sir multiple polyps which are involving the duodenojejunal junction.
Okay, next some more common possibility.
Sir, more common sir nodular hyperplasia.
Something most likely.
Sir, something most likely in the
Okay, remember we have seen in CT also, we have seen in Barium studies also. Remember the lymphoma,
yes, sir.
especially when it is cellular predominant. It do grow, it do obstruct, but the flow, the passage also continue. It
Yes, sir.
trickles on, it goes on, and then one day it obstructs, and then pain, obstruction, vomiting, and then imaging, and then it is diagnosed.
Yes, sir.
It was a large lobulated mass inside the lumen, pedunculated inside the lumen of DJ, and on its scan histopathology, it was again lymphoma. Okay,
Sir,
quite.
lymphoma doesn't cause sir, a significant obstruction of the bowel, so that's why I am not thinking
That's
about
why.
lymphoma.
That's why it goes on for 8 to 9 months or an year. Okay.
Yes, sir.
These are the multiple spot images of the double contrast barium meal follow through of the adult patient which is suffering from off and on pain, in which I can see that the contrast is opacifying and passing from the stomach, uh, uh, also pacifying the uh, duodenum and jejunum. However, uh, the contrast is
Okay. Can you play with some arrow to just indicate where is duodenum, where is jejunum in this case? 1 hour film and then 3 hour film.
uh,
Can you highlight for me? Is it possible?
I think so.
This is not possible for her to do this because you are doing the screen sharing, so the mouse is under your control. She can only explain.
Sir, on the right, sir, I can see that the
Okay,
small.
what is this part?
Sir, this one is transverse colon, sir.
You are asking or answering?
Sir, answering.
Okay, what is this?
Sir, this one is ascending.
Good. Hepatic flexure. Okay.
Yes, sir.
Then
Sir,
what
and
is this?
sir, this one is ileocecal junction, in which I can see that it is appears narrowed and the cecum appears coned to me, coned, sir. And the contrast is retrograde filling is also noted. That is of the
Retrograde.
small bowel.
It is very meal follow through study. You can
Yes,
just be sure on this. 1 hour film, then 3 hour. In anemia, we don't give these
time.
time-based marking. It's only in barium meal follow-through study we provide the time of the film taken of the oral intake of the contrast. Okay, in anemia, almost never. And
Right.
this is confirmed barium meal follow-through study, and not at all retrograde thing. It is all the way antigrade.
Yes, sir.
Okay,
Yes, sir.
now
Uh,
describe it.
yes, sir. In which I can see that the ileum appears, ileocecal junction appears narrowed, and the contrast is opacifying the cecum and the ascending colon. However, the cecum appears somehow irregular in shape, and mucosal irregularity is also noted along its walls. However, there is however, there is a filling of the ascending colon up to the transverse colon also. Uh, sir,
and in which in my provisional diagnosis I will keep it in the I will ask the patient about fever, any night sweats, and will likely to put it in the case of tuberculosis because the ileocecal junction appears narrow to me, sir.
Very good. It is a typical case. It is it was diagnosed as that, and in correlation with the age. The next possibility is Crohn's, but
Crohn's.
we don't see in this case the fistulae and the sciplians. They are not there, and at the same time, in tuberculosis, there is shortening of the length of the A colon. Okay,
Oh,
the
yes.
lead, the ileocecal junction is a little hooked up,
Yes.
and
Due to fibrosis.
at the same time, you see one hour film and the whole T colon is even opacified. In spite of this irregularity, this narrowing, and there is all over a hurried passage of the contrast in the small early washout and a little space over there, and then again hurry. This hurry is very much suggestive of peritoneal inflammatory reaction and peritoneal involvement and a diffuse reaction, and then the epicenter is here. And
Yes, sir.
this is the most common site for for intestinal tuberculosis. Lot many cases ignored for years and years, and then when treated, it is too late. The earliest you pick it, the earliest you treat it, the best is the prognosis. And deformed ileocecal junction, you must keep in mind the three, four, five possible causes: ileocecal
Yes.
TB, Crohn's, old age, ileocecal CA, and young age ileocecal lymphoma. For that, there are just one, two differentiating point. You can give the probability. Again, the confirmation and the specific diagnosis is with histopathology. Never to miss that. You have to reach to that at your own. Okay? Please.
So I am provided with two spot films of barium anema, signal contrast study, frontal and lateral projections of a skeletally immature patient who presented with acute abdominal pain. And in the first film, I can see that the contrast is specifying the rectum, sigmoid colon, descending colon, and transverse colon up to the hepatic flexure. And I can see the Foley's bulb inside, and the normal hostration pattern is noted with a visualized large gut, large colon, and no filling defects abnormal are noted. While in the lateral film, I can see that there is abrupt cut off of the barium contrast at the level of the right colic flexure, hepatic flexure, making a claw sign, and paucity of the contrast is noted going proximally. However, few dilated small gut loops are noted, which are gas filled, and no contrast is noted within the small gut loop, and no any pneumoperitoneum is noted, and no any extra peritoneal spillage of contrast is also seen. So as the patient is a young child and the history is acute, so on the basis of these findings, I will first suspect ileocolic interception in this patient. This will be my first diagnosis.
In such a typical finding, such a class time, you should be very confident. These films are to help you out for saving your time for other cases.
Yes.
Straightforward. Okay, typical finding. Okay, can you guide me how to reduce it?
Sir, it can be reduced by osmotic. There is osmotic reduction and there is pneumatic reduction.
So X-ray abdomen, frontal projection and lateral view showing multiple few gas loops seen in the mid abdomen, and few prominent gas loops are seen in the mid and the upper abdomen. The lateral view, I am not able to see the gas seen extending beyond the distal most part of the rectum, as well as an external metallic marker is seen. So the findings are more in favor of
Okay.
intensively treated.
Very good. This is important to be noted on plain film if it is provided like that. Okay, another finding is there. Okay, can you?
Yes. Anal atresia and
Okay, that is to be suspected of it. Coloscopy at 1 week age.
yes.
And don't miss this. What is this?
This is an abnormal soft tissue density area noted in the region of
No.
anterior to the sacral region, anterior to the sacrum. So the differentials of the soft tissue density area, it could be anterior sacral meningocele.
It is sacral hypoplasia, sacral hypogenesis. Okay, give me the finding now. Contrast study.
So the contrast studies are showing the opacification of the distal part of the rectum as well as the urinary bladder, and abnormal communication is noted between the two. So the findings, along with the metallic marker on the surface of the skin, so the findings are more in favor of anal atresia as well as rectovesical fistula, abnormal communication between the rectum and the
Very
urinary
good.
bladder.
And that area you have to grade. It is high level, low level. You have to
Yeah,
be
it seems to be
clear
more
on
than
it.
yes, high level anal atresia. So I would further like to correlate with the history of the patient as well as refer the patient to the pediatrics department for anal
Very good.
pull-through
In
surgery.
your
And
description, be alert to look for the featureless communication. This was shown in an exam, and the great candidate was telling this as sigmoid colon. And such blunders, they do damage a lot. Okay, don't mix it with S colon. Okay, don't miss this outline of urethra. Don't miss this featureless communication. Okay,
Okay. I'm provided with a upper GI contrast series where there is a contrast opacification of stomach, duodenum, jejunum, and small part of ileum. Uh, there is normal filling of contrast in the stomach
small
and
part of what?
small bowel. Yes, sir.
Uh, you spoke small part of volume.
Yes. Jejunum.
Okay,
No, I cannot see the ileum.
okay,
Sorry.
it's you know. Okay,
Yes.
go on. Continue, please.
There is yes. There is the dilatation of the duodenum, and in the jejunum, I can appreciate the bowel wall thickening because there is bowel wall thickening, and however, contrast is seen passing through the bowel lumen. I cannot appreciate any mass lesion in the provided images.
G.
In the stomach greater curvature, I can appreciate pooling of the contrast along with the striations along it, suggesting some ulceration in the gastric region.
G.
And the ulcer looks benign.
The way there is a filling defect. It is head down lying spine film. It is erect film giving you horizontal airfield level in the fundus, and even then
Yes.
persistent. There is a long snake-like filling defect up to this. If you perceive it, this is just a pooling of contrast in a little dependent portion. This is not at all ulcer because it is being outlined by the outer wall of the stomach. Okay? Don't take it as a malignant ulcer or otherwise, and this young age. And this long filling defect, to me, believe me, to me, this is one of very easy film to be interpreted. And looking at this, you see in the lying film, you see this filling defect all the way in continuity. In this film, in continuity of this. And this is typical of one thing. What is that?
Worms?
What?
Intestinal worms?
Worms, they do take the contrast, and then there is the double
Yeah.
study of the barium of the worm, barium, so meal follow through of the worm, and then
It can be any bizarre,
mm,
trichobizarre,
very
or
good.
Okay, sir. These are the spot images of the barium meal follow through study, single contrast study. Contrast opacifying the stomach, which is outlined normally, and then contrast passes distally in the duodenum and the small bowel. However, there is the mm, duodenojejunal junction is normal, and however the contrast passes through the duodenum in the small bowel loops, and the so there is the pattern of jejunal is not very well seen as normal, sir, and the um, after nine 3 hours film, 9 hours film. Okay, sir. Sir, there's delay transient in the passage of the contrast is noted from the small bowel, and sir, sir, is there any history of surgery?
No. For flocculation, if you say there should be a lot of fluid, there should be floating contrast, and somewhere concentrated, somewhere diluted, that is flocculation. It is segmentation, and it is segmental spaces,
It's in
and
the structure narrowing, sir. Segmental narrowing in the broad. Alternate the third narrowing away. STPL like.
you can't specify any structure. Okay, it may be over here.
Yes, sir.
Later,
Yes, exactly.
in
Yes, sir. This is present.
identification are deformed.
Yes,
There
sir.
is a passage of contrast into the colon also at 9 hours.
Yes, sir.
Note
Same
the
is
fixation of the A colon at 3 hours. Okay, with all this outlook, with this age, what is your diagnosis?
effective etiology, sir. Tuberculosis, top of the may be contracted cecum में ileocecal junction से narrow deformity.